The first discontinuation trial was the STIM trial. It was a study done in France starting in 2007. They enrolled 100 patients, all being treated with imatinib, who had achieved undetectable levels of BCR-ABL and maintained those deep responses for a minimum of 2 years. And those patients then discontinued their imatinib, and they were just followed off treatment until molecular relapse. That's, again, the data from that study is the oldest data we have now, and the long-term follow-up was published about a year and a half ago with 77-month median follow-up time, and 38% of patients remain off treatment even years out. So that was the first study, kind of a proof of principle that discontinuing therapy in a subset of patients is feasible. The largest discontinuation trial that's been done to date is called the EuroSki trial. They enrolled 848 patients in Europe on all TKIs, 448 of them on imatinib. And again, very similar data, slightly higher rates of treatment-free remission on that study, likely because of potentially less stringent criteria for restarting therapy. So that study, again, was able to help define criteria that must be met for patients to be eligible to stop therapy. And then the final study I'm going to be talking about is called the INEST-STOP, which is a study looking at patients treated with nilotinib as second-line therapy. So treated with imatinib as first-line therapy, those patients did not achieve undetectable BCR-ABL, or a result of MR 4.5. So then switched to nilotinib and then achieved MR 4.5. Remained on nilotinib for a period of time and then came off treatment. And again, very similar results. The data from this study is now out to 144 months. Again, most of the patients who relapsed did so very early on. There's about 50% who still remain off therapy even now. So again, suggesting that even in second-line therapy, if you're selecting the patients appropriately, we do have a small subset who are able to successfully come off treatment.